No, I think just name and title. And before I introduce them, I'm just going to say a little bit about background about the webinar. And then just before they speak, I'm going to introduce them. So I'm going to just say we're coming to the end now and thank our experts. And then I'm going to tell them about next week's webinar so that they encourage to choose. Welcome to this Discovery Health webinar on COVID vaccines. Today, I am Mia Malan. I'm the editor of the DiscoverySA Center for Health Journalism, and I'll be facilitating this discussion. Now, today's webinar is the first in a series of 4 Discovery webinars that will look at COVID vaccines, and we'll focus on various issues. We'll look at how vaccines work, and we'll also look at how well and safe they are for pregnant women to work. We'll look at children and COVID vaccines, and we'll also see if there's any relationship between fertility and COVID vaccines. Now, all these webinars will take place on Fridays at 12:30, just like today, and you can keep an eye on Discovery Health's social media platforms to get information as to when they will happen. Now, these webinars, of course, come at a time when we are in a race to vaccinate as many people as we can before a 4th wave of COVID would arrive in South Africa. And some experts predict that it may be as early as mid-December, so it's not so far away. And that's why there is a need for credible information around COVID vaccines. And with these webinars, that's exactly what we're trying to give you, and to also give you the opportunity to ask your questions to experts that we will have available. So today we do have 2 really brilliant experts with us. We have Professor Helen Rees, who is a member of South Africa's Ministerial Advisory Committee on COVID-19 vaccines, and she's also the board chair of the country's medicine regulator, the South African Health Products Regulatory Authority, or SAPRA as we more commonly know it. So it's really great that we can ask questions about that to Professor Rees. Professor Rees, thanks very much for making the time to join us today.
Thank you very much.
We also have the head of Discovery Health Center for Clinical Excellence, Dr. Noluthando Namatswerani, with us. Dr. Namatswerani, thank you for making the time to join us today. And both of our experts are also medical doctors, so we're in safe hands from all aspects today. So we've got about an hour today for our webinar, and I'm going to start off with our discussion by asking our 2 experts questions for about 20-25 minutes, and then we are going to ask them your questions. Now, some of you have already sent in some questions before the webinar. We've received many questions, so we may not be able to answer all of them, but Discovery has committed to working some of these answers into their content so that those that we don't get to today is also addressed in some way. We also encourage you to enter your questions on Zoom today in the chat box so that we have a combination of the questions that were asked before and also some of those that you are going to ask today. So I'm going to start off with Professor Rees today with a question. Professor Rees, we all want to know that when we take a vaccine, that it's safe and that it works. But COVID vaccines were produced within a year, a very short period. So how do we know we can believe that data, that it's safe and effective? And maybe you can compare it a little bit to the malaria vaccine that we heard about this week.
Well, if we start with the malaria vaccine, that's been a very difficult vaccine to crack. And it's taken many years to get a partially effective vaccine. But nonetheless, that is very good news. And importantly, the work that was done on the malaria vaccine was precisely to establish that when it's used in children, that it's safe. And many tens of thousands, nearly 1 million children were enrolled in pilot studies to evaluate that. So that's very good news. And that's more traditional of some of the struggles we've had with vaccine development. So it's a good question, because that some vaccines took many years, like the polio vaccine, to develop. Others were quicker, like the whooping cough vaccine. And some we're still struggling with, like HIV. So what was different here? So first of all, following the Ebola outbreak, if you all remember that in West Africa in 2014, the world recognized that we weren't ready to press a quick go button to develop a vaccine quickly. It took us a long time. We were all in meetings discussing how to evaluate a vaccine in the context of the Ebola outbreak. Eventually, we had one study that was able to help us, and we did get an Ebola vaccine. But after that, the scientific world said, let's do things differently. Several things were looked at. One was, let's look at pathogens that are likely to cause epidemics, outbreaks, or even a pandemic. Some of those are neglected. Ebola was neglected. Something like Lassa fever that occurs in our continent. These were neglected. But we also said we need to look at the pathogen that we don't yet know. We called it pathogen X. And in this case, it's turned out to be the SARS-CoV-2, the COVID-19 virus. So in order to get ready for this, we did several things. One is we started to develop vaccines for some of these other diseases that we were worried about, MERS and SARS, for example. Secondly, we developed what are called platforms. These are, if you like, the base of a vaccine, and then you can plug new pathogens into them. And this is, many of you have heard of the mRNA vaccines. This was one of those platforms that has been developed precisely because we've been worried about pandemic pathogens that we don't yet know. So when this started, we were able to very quickly take off the shelf MERS and SARS vaccines in development and change them. We were able to take the mRNA platform and the Ad26, the adenovirus platforms, and change them quickly from other vaccines into a COVID-19 vaccine. The second reason why we were able to accelerate was that the Chinese government very quickly, the Chinese scientists shared with the world right at the beginning the genetic makeup of the COVID-19 virus. And because we got that right at the beginning, and we had these other vaccines on the shelf, we were able to say, that's what this virus looks like. Let's modify it, plug it into these new vaccines. And then the third thing that we did was we took everything that we know about what's needed to develop a vaccine and we condensed it. We overlapped things. In the past, we would tend to do early clinical trials with small numbers of people and evaluate and do this and that, wait a while, evaluate the data, then go into a larger trial, wait, evaluate. Instead of that, we overlapped everything. But we didn't miss out a single step. And we gave initially emergency use authorization while we continued to collect more data as we rolled the vaccines out in the field. So for reassurance sake, this has changed the way in the future that we're going to develop vaccines. We're not going to go back to the 30, 40, 50 years of polio development or malaria. We are going to now, the ambition is to be able to develop a vaccine in 100 days. That's the new global ambition from what we've learned for COVID. So reassurance, every step was taken, condensed, and we had already learned some lessons from the Ebola outbreak.
Thank you so much, Professor Rees. And that brings me to, we have two vaccines that we use in South Africa, the Pfizer and the Johnson & Johnson vaccine. But we hear about so many efficacy figures going around. Sometimes we hear about how much they protect you against serious COVID and prevent you to go into a hospital. And sometimes we hear efficacy figures, protection against infection or all forms of COVID. Can you, in easy language, tell us what does the Pfizer and the J&J vaccines protect us against, and how well do they do these? Are they different? Is one better than the other?
Pandemic was to stop severe disease, hospitalization, and death. So in all the clinical trials, those were some of the indices that we looked for. We said, is this vaccine going to do that? Many of the vaccines are not as good at stopping moderate or mild disease and not as good at stopping asymptomatic disease. But all the vaccines, and particularly these two vaccines that we have, are good at stopping severe disease, hospitalization, and death. So with the original clinical trials, that's what we measured, and we were seeing figures for the mRNA vaccines of over 90% for severe disease, and for the J&J vaccines, for the adenovirus vaccines, up into the late 80s for protection from the original trials. The next thing, though, we've had to tackle is the new variants. With every variant of concern, and you've heard us talking about alpha and then beta we had, and now delta, these are what we call variants of concern. The virus has been good at changing itself. Viruses change all the time, and many of the changes are inconsequential. It's still the same sort of virus, it behaves in the same way, it doesn't make a difference. But sometimes the changes that occur as the virus replicates are advantageous to that virus. The Delta variant, for example, is more easily transmitted. You get more virus in infected people than you saw in the original infections. And it appears to cause more severe disease and slightly different symptoms in disease. So that virus has now changed, and the Delta variant has done that. But for each of these variants that we've seen in the laboratory and clinically, but first off in the laboratory, we've looked at the vaccines and we say, do these vaccines still work against this variant? And what we found is that the variants of concern are also more resistant to the beneficial protective effect of a vaccine, but they all still work. So not as highly effective as we saw with the original clinical trials. All of them are impacted, particularly by the Delta variant, but they all prevent to a very large extent severe disease and hospitalization. And both the J&J and the Pfizer vaccines are extremely good vaccines, and for most people will be highly protective.
Thank you very much, Dr. Nematsorani. We've now heard about efficacy, but why do we only need 1 dose of J&J and 2 doses of Pfizer? Why is there a difference?
So that's an important question. Obviously, it depends on the amount of the vaccine that can induce that quality of immunity that we're looking for. So with J&J, you have to compare, obviously, the level of immunity that you get with that vaccine and obviously the duration of that immune response. And if you get an equivalent response from a single dose to what you could get with a double dose, then it explains why you could have different dosing schedules, but you still get the same benefit. So it's really how the different technologies work. But in terms of measuring what it is meant to do, you still get, like Prof has indicated, you still get the same protection against severe illness and death. So I think we do see this with other medications as well. You can take 1 dose of one drug and get the same effectiveness or efficacy as taking 2 doses. It just depends on the formulation and also in terms of the dosing that you require to get to that level of immunity.
So if we then look at the 2 doses of Pfizer, our health department says we must wait 42 days after the first dose to get the second. Why do we need to do that? Why can't we just get a second dose a week after the first dose?
So it's important. So the first dose, we almost we view that almost as a priming dose, meaning that you challenge the immune system, but then your second dose almost boosts that immune response. So if you note that the data that is coming out in terms of how the level of immunity that you get from a single dose, it is not as good as, when you've received your second dose, which is why we only consider you fully vaccinated after the second dose, after 2 weeks of your second dose. What has come out of the literature is that the timing of your second dose is also important. The longer you wait, you actually allow your body to have a better response in terms of immunity. And I think there are trials that actually now go beyond the 42 days that we're looking at. But, as that data becomes even stronger, we can start saying maybe the dosing interval could even be extended beyond the 42 days. So it is really about getting the science to guide us in terms of the best and the optimal, immune response that you can get depending on, if you think about the Pfizer vaccine, for example, when it was first introduced by Pfizer, the dosing recommendation was 21 days after your initial dose. But, if you look at those initial trials, there was a time interval that extended to 42 days. And we were guided by science to say you can still extend to that level and not compromise on the immune response that you get. And I think Prof can also maybe, just confirm here that, it does appear that the longer the dosing interval, the better the immune response, with that second dose as a boosting dose to the primer first dose.
Professor Rees, did you want to add to this?
Yes, no, it's quite right. And just remember, these are new vaccines and a new disease. It's a new virus we've never seen before. So we are learning, and I think people should be pleased that the scientists are learning. I don't think none of us have ever seen such intense focus on trying to understand what's happening so quickly. And many of our best scientists in this country and globally have turned their attention now to COVID research, whether they're lab or clinical, etc. So we are learning. So just a few things. I think people are familiar with childhood vaccinations where you'll go for one measles dose and then you have a second dose later on. Some of the childhood vaccinations require 3 doses, and that's called the primary series. And so when we give a vaccine, we want to say, first of all, for the individual person, what dose of vaccine, how much antigen, which is what's in the vaccine, how much do I need to give you to get an immune response? But how do I get the best immune response with the first, what we call the primary series? The first group of vaccines I give you, I want to give you as an individual the best protection. And so that will be 2 doses, 1 dose, 3 doses, and it depends on the vaccine, and it also depends on the nature of the pathogen that you're trying to fight against and protect against. So it will vary from vaccine to vaccine, from disease to disease. So with the Pfizer vaccine, it's quite right. We started off with a much shorter interval, but then data from the laboratory and clinical data showed us that a longer interval is better. And this is what we call the primary series. This is to give you at the outset the best chance. But then we watch you as an individual, and we say, what happens to your immune response over time? And we do see with all vaccines, even with natural infection, the antibodies go down with everybody. They'll go down. With some vaccines, they'll go down more quickly. With J&J, they seem to stay a bit more stable, but they start at a lower level. So then we say, at what point do we have to give another dose? Do we have to give another dose or don't we? And if so, when do we give it? So in fact, for J&J, the questioner asked this question about why 1 dose. In fact, interestingly, we're thinking now, both nationally here and worldwide, about whether we will be giving a second dose. So just watch that space, because we're looking at all the data and deciding whether, in fact, to keep your individual protection up, we need to give you a second dose.
If we look at second doses, Professor Rees, who will get those first? Will it be the health workers in the Sasonki trial that were vaccinated long ago, or will it be older people? Who will be prioritized?
It's a good question, because one of the limitations, particularly in the African region, is access to the vaccines. And J&J has had some problems with manufacturing and access. So we haven't had the same flow of the just 8 months out in terms of retaining that level of antibody response and retaining its effect. But we're thinking that it would probably be people at about 6, 7, 8 months, that sort of longer period that we would want to give a second dose. So very likely we will look at the healthcare workers who were the first to receive it, but we will also look at, as you say, those who are at higher risk of severe disease. And it will be the over 60s, and it will be people with significant comorbidities. But we will probably start with the groups that we first immunize, because we want to get them first with a second shot, if that's what's agreed to. And that's what's currently under discussion between the Department of Health, the Minister, and the VMAC.
So Professor Rees, you're on SAHPRA's board, and there's so many questions, particularly on social media, going around about how do we know what is inside of a vaccine, what are the ingredients, and might it be toxic to our bodies? So how much of this do pharmaceutical companies disclose when they apply for approval with SAHPRA so that their vaccine can be used in South Africa?
They have to disclose everything. Everything has to be disclosed. And we back it up with all sorts of checks and balances in terms of data. And even when we issue an emergency use, so not full registration, but an emergency use, that kind of information has to be disclosed. So we know exactly what's in a vaccine. And the most important ingredient of the vaccine is what we call the antigen. This is the trick that we're delivering with the vaccine. And it's the thing derived from, in this case, the virus, that the body will recognize. It's not the virus itself, it's a piece of the virus, or it's a little bit of genetic material that generates a little protein of the virus. The body recognizes that, but it recognizes that little piece, and it mounts an immune response. And then when we get the actual virus, the body recognizes that small bit and mounts an immune response. But we don't have to give the actual virus in the vaccine to the person to generate that. So what we will see in the vaccine is what we call the antigen. What is that trigger piece? Whatever it is that's going to stimulate our immune response. Some vaccines will have what are called adjuvants. These are sort of extra pieces of the recipe that boost that immune response, strengthen it, make our bodies react more strongly. Then there will be stabilizers. Then there will also be diluents, things that will dilute a vaccine. And we also have to preserve the vaccine. So you have to have preservatives. So SAPRA will look at the way the vaccine is made, but we will also look at how it's being manufactured. And this is very important. And we've worked very closely with the World Health Organization because they've been in some ways able to inspect manufacturing sites that because of COVID, we were not able to send inspectors around the world to inspect. So we're working very closely. So you look at the ingredients, you look at the manufacturing sites, you say, are they able to consistently produce something of high quality? It's extremely important. And then you look at all the preclinical data. This is, what have we seen from the laboratory? What are we seeing from animal studies? And then the clinical data that has existed so far, and these early studies looking at safety and dosage. Then the larger secondary studies, the phase 2 studies, looking again at safety, but also starting to look at the immune response and the effect. And then these huge phase 3 studies of 20, 30, 40,000 people, which ask the question, does the vaccine work? So the SAPRA will look at all of this data, and even when it gives an emergency use authorization, will require the applicant to continue to produce data for us on safety and on effectiveness. And if there are any other specific questions that we need data from, we would ask them. And the applicants have the right to continue to give us data. Many of the vaccines we're now seeing, for example, are doing trials in children or in adolescents. As that data comes through, the applicants of each of the vaccines that we're looking at that SAPRA has approved can add that data to their file, and SAPRA will then evaluate it and say, can we give this to children 12 to 18, for example? So it's a very rigorous process, but it's a hugely condensed process. We have roped in external experts. We have got teams and committees of people looking at this, and we have really compressed the approval time into weeks because people are working all night and over weekends to accelerate the approval processes.
Thank you, Professor Rees. Just on that, so there are also other vaccines. Sinovac has been approved with conditions, and we know that Sinopharm and Sputnik are under review. Does SAPRA ever not approve a medicine? So is there a deadline where you would say, no, these, this one and this one, we're not going to approve, or is it just an indefinite process?
No, it wouldn't be an indefinite process. If we saw something that didn't, for example, meet our quality specifications, it wouldn't go past go. If we saw that there were problems with the manufacturing, then that would be a significant challenge for us. If we found that the levels of efficacy from the trials were not good enough, it wouldn't go past go. We've set a benchmark, which is what we've set and WHO set us. We're looking for at least 50% as our benchmark of effectiveness against severe disease. So we're looking at that benchmark, and that's pretty much a global benchmark to say go, no go. So if you've got something now that's 35% protective, it wouldn't pass that benchmark. So certainly vaccines and other medicines as well, for a huge number of reasons, if they don't come up to the safety standards, the quality standards, and the efficacy standards, they would not get approval.
Thank you. Dr. Namaturani, we've now spoken about how vaccines are made, but let's look at how they work. Can you, in very easy language, explain what is the difference in the way that the J&J and the Pfizer vaccine work? What is the difference in technology that they use?
Okay, no, thank you so much. I think we need to start by just saying vaccines, the vaccine technology has been in place for many years, and I think Prof spoke to that vaccines are not new to us. And I think the important thing to understand is really that vaccines help to train the immune system. So you are almost introducing a fake infection so that your body views it as almost the real thing, and you mount that immune response. So you produce those antibodies and that other, level of immunity that says, I must remember in future. So the memory cells that are there, that says, I will remember in future when I'm faced with the real thing to fight. So that's how vaccines work. It's really a safe way of training the immune system against infection. Other people can actually train the immune system, not training per se. You still get immunity by being exposed to the real thing. So that's where we talk about natural immunity. So vaccine immunity is a safe way of training the immune system. So the two vaccines that we're talking about that are currently being used in South Africa is the Pfizer vaccine, which is an mRNA vaccine, and the J&J vaccine is the viral vector vaccine. So the mRNA is really a messenger RNA that is introduced to the body. It instructs our cells to produce the spike proteins that are similar to what you find on the surface of the coronavirus. And those spike proteins cannot actually cause infection, but they are then exposed on our cells, and the body recognizes that as an infection, but we know that it is not the real thing. But then it clears that infection. And that's where, you do get side effects because of your body's response to the vaccine. You get your headaches, you get your fever, chills, which is that immune response that is mounted when you have received the Pfizer vaccine. It doesn't enter our nucleus in the cell, which is where our DNA is, because people are worried that it can alter our DNA. So the messenger RNA, that whole protein synthesis, that process is stimulated in the cytoplasm of the cell. And therefore, we should not be worried about, altering our DNA. And once that process has been finished, the spike proteins are, broken down. Within weeks, they are no longer in our systems, which is another important point, because people feel that, these spike proteins might be accumulating in the body and in the long term may cause problems. Similarly, when we think about the J&J vaccine, which is it uses an adenovirus, which is a harmless inactivated form of this particular virus, also exposing the spike protein into our bodies, and therefore the body also recognizing this as an infection and mounting that immune response. So if you think about, both, ways that the spike protein is introduced into our bodies, it is not really to cause a real infection, but it is to create an impression that you are infected with the real thing. But then your body does not know that. It mounts an immune response that would have been similar to when you are exposed to the real thing. This helps us because in future, when you are faced with the real thing, you already have got that awareness, and the body is able, therefore, to prevent severe illness and death, as is the aim of vaccinations. I hope that clarifies. And I think, when we think about CoronaVac, which has also received conditional approval, this is a whole virus that is inactivated with the spike proteins that are preserved so that you can still, introduce this virus that cannot actually cause harm in terms of giving us an infection, but allows our bodies to prepare for future infections and making sure that we are well armed, if I may put it that way.
Thanks very much for that. And of course, the CoronaVac vaccine that Dr. Nimatswarani referred to is the one from Sinovac that comes from China that has received conditional approval in South Africa. So we're going to move on to some of your questions now. And there is a question that relates closely to what we heard now about mRNA vaccines, which is the Pfizer vaccine. And I'm going to ask that to Professor Rees, because Vernon says there are a number of world-renowned doctors, professors, and scientists who are against the rollout of mRNA vaccines because they say they're still in the experimental stage and are concerned about the long-term effects of these vaccines. So do we really have enough of the data that we need? And do we have any long-term data to know if they work?
So, Thank you. No, and a good question and a fair question. So first of all, just to say that the mRNA platform, it is indeed a new platform, and people are very excited about it because it's one of those platforms that I was saying earlier on, has the potential in the future to be used if we have another new pandemic virus, pathogen X, virus X. We don't know what it is yet. It's going to pop up. It has the potential to quickly be adapted. Secondly, it's a manufacturing technique that can be exported, and we can get tech transfer. And we've already seen in South Africa, for example, that we are hoping to set up an mRNA manufacturing hub in Cape Town. So on those counts, it's exciting. But the question in hand, so this has been in development for a number of years. It didn't suddenly get invented now because of COVID. This platform has been in development for a long time, and is actually was a platform that was first thought about for things like cancers, but also HIV. So people have been thinking about this for some time, but has obviously really now absolutely burst into its own with COVID. The safety profile of this vaccine at the moment, now it's been given to millions of people worldwide. The safety profile looks very good. What we're picking up are rare side effects that can be serious, but they're extremely, extremely rare. And if you compare the incidence of those to the incidence of those conditions, if you catch COVID and you get severe COVID, then the benefit of the vaccine far outweighs the risk. And particularly people will have heard about inflammation of the heart muscle, which we call myocarditis, which we've seen rarely, but mostly in young men, interestingly, but extremely rarely. It's been self-limiting for nearly everyone who has had this. It's very, very rare. And as I say, damage to the heart and problems with the heart are much more common when you get COVID and severe COVID. So benefit massively outweighs the risk. So we've now got safety data on millions and millions and millions of people. We will continue to collect safety data. There has, I don't think, ever in the history even of vaccines, because of the speed of rollout around the world, been such attention paid to collecting safety data and analyzing that data. And that includes here in South Africa, we have a very rigorous process of analysis going on. So we will watch that space, but there is nothing at the moment to indicate that this is going to cause long-term harm at all. And in fact, I think what we will see is that many more vaccines will be developed in the medium to long-term future for many other diseases using this technology.
Professor Reza, I'm going to stay with you because there's another SAPRA question from Eugene. And he asks that, he says SAPRA refers to a rolling review process to accompany the rollout of vaccines. And he wants to know, is it fair to say that we are getting vaccines that are indeed part of an ongoing trial?
Well, not in the sense that he's asking, but I'll clarify that. So every regulator around the world has had to respond to a pandemic with various forms of emergency use permissions. And the legislation that allows different regulators to do this varies. In South Africa, we have legislation that allows us to give an emergency use permission for, in this case, a vaccine to be used. That emergency use permission requires still a lot of data. It's done as quickly as we can, as I was saying, but it requires all that data I described to you. What is the vaccine? What's it made up of? What is the quality of manufacturing? What do we see in terms of safety? What do we know about efficacy? What do we know about the immune response to the vaccine? All of that data has to be there. But we also know this is a pandemic. Now, I don't think anyone who wants this pandemic to end would say, well, wait till you've collected in a clinical trial tens of thousands, hundreds of thousands, hundreds and hundreds of thousands, and follow them up for 9 months, for 12 months, or 2 years before you allow it. A pandemic is an emergency. It's a global health emergency, and all regulators worldwide have had to respond in the context of an emergency. And most regulators have legislation that actually allows them to do this in emergency, because we know in public health there will be such emergencies. So when we have to have all of this data before an emergency use approval, but we also know that the applicants, the manufacturers, are continuing to collect data. They're rolling data out. They're looking at different age groups. They're looking at pregnant women. They're looking at younger children. So we're saying, we want you to keep giving us all the data you've got, all your safety data, all your effectiveness data, all your special group data. We're looking at people living with HIV. We want that data from you. We know when we first give emergency use, you won't have all that data. So we want these clinical trials to continue, very much so. We're asking the manufacturers to develop that data. For example, pregnant women is an incredibly important group we need data on. So we're asking for that data. But this does not mean to say that this is just one huge global clinical trial. No, these are now vaccines that very soon will have full registration.
Thanks, Professor Rees. Dr. Namatswarani, we've now heard about heart inflammation as a side effect that is rare, but Professor Rees did mention that in regard to the Pfizer vaccine. If we look at the side effects, the very severe side effects and how commonly they occur, how do they compare against other vaccines that we know? Do COVID vaccines have more or severe side effects compared to other vaccines, or is it more or less the same?
Definitely not more than other vaccines. I may not be able to give a comparative state right now, Mia, but if we think about, some of the severe side effects that have been reported. So Prof spoke about myocarditis. We know about severe allergic reactions with Pfizer vaccines, which are also very rare, less than 10 in a million doses administered. We know about the J&J vaccine. I think people have been worried about some of the severe side effects like clotting, which has also been seen in very rare cases. 5 to 7 in a million doses also. And also we've seen cases of, Guillain-Barré, which is a severe adverse effect that usually is as a result of our immune response attacking, our nervous system, people presenting with weakness. So these side effects that are rare, remain rare and really. Also, if people can pick them up early, they're usually easier to manage. And, we've seen successful treatments for these side effects. So I think people need to know that these continue to be monitored, and as they emerge, they are reported and the public is made aware. And I think the most important thing is understanding when to seek emergency care post-vaccination when you suspect that you may be having any of these severe side effects. But the common side effects are also well documented, where people experience, pain around the injection site. People experience fever, chills, headaches, muscle aches, tiredness, and some people do get a bit nauseous. But these are really in the immediate period post-vaccination. And the rare ones, we always encourage people, once you start experiencing severe headaches, severe abdominal pains, severe chest pains, severe leg pains, please reach out to your healthcare professional so that you can be assessed properly and make sure that, you are managed accordingly. And some people may experience effects that are not related to the vaccine, but they may be coincidental around the time of getting vaccinated. So that's why healthcare professionals need to make that assessment. But like I'm saying, these are rare. We're not discounting that they do happen, but if we think about the risk benefit of giving a vaccine and saving millions of lives versus these rare side effects, which can be easily identified and treated, we believe that this is still a safe intervention to provide.
Professor Rees, we now have heard about the side effects, but there's a question from John who asks, if the side effects, if the vaccines are so safe, why are COVID vaccine manufacturers exempt from liability for severe adverse events? In other words, very bad side effects.
Well, the liability has been taken on by governments worldwide, or by special donor agencies. I think it's a good question. With time, I'm sure that will change once we get full registration and these things are being properly rolled out. But I guess the manufacturers, from the manufacturer's perspective, and I haven't spoken to anyone in depth to know this, they recognize that they were putting themselves at risk by saying, yep, we're going to develop this rapidly and we're going to get it out in millions onto the marketplace. So we need to share that risk. And that was one of the reasons that they asked, as I say, a variety of third parties to cover that risk. But just to reassure people that people are covered for any risks, should there be a vaccine-associated, any sort of severe vaccine-associated reaction. But at the moment, these are so rare, we're just really not seeing them in any huge numbers, not at all, not at all.
Thanks very much. There's also a question, Dr. Namasurani, from Samantha Pretorius, who wants to know, how will the vaccine affect me with my chronic condition? And I guess that relates to if you undergoing, for instance, if you have a chronic condition, or if your immune system is very weak, if you may be having chemotherapy because of cancer, can you still get vaccinated? Is it a good thing?
Yeah. Mia, this is an important question, and I think people need to understand that underlying chronic conditions, we've seen diabetes, chronic lung disease, hypertension, and other underlying heart disease, people with immune systems that have been suppressed because of medications that they are taking, people with autoimmune diseases, people with cancer. These people are the people who are most prone or predisposed to getting a severe COVID illness. And these are the people that want to protect vaccinations from severe illness and death. And I think if people can just understand that piece, that the infection itself is more dangerous for people with underlying chronic conditions than the vaccine would be. Actually, the vaccine we would like to prioritize people with chronic conditions because they are the ones who are likely to end up in hospital, they are likely to die. What is important though, and it goes back to some of the dosing schedules that we could be looking at, where we're saying they may also not mount a sufficient immune response when you compare it to people who have got strong immune systems. So which is why they may be prioritized for more doses to make sure that they get sufficient protection against severe illness and death. But definitely if you've got a chronic condition, you are more likely to have severe illness, and therefore the vaccination is actually an ideal protective measure for those people.
Dr. Namasurani, I'm going to stay with you because there are quite a few questions about natural immunity. People want to know, what kind of protection does natural immunity give you? So if you've had COVID and that immunity that you get, how does that compare to the immunity that a vaccine gives you? Does it last as long? And if it's good, why do you need to be vaccinated against COVID? Why can't we just say you have natural immunity, you don't need a vaccine?
So I think this is another important question. So we do know that obviously after you have been infected with COVID, you do develop immunity against the infection. While we have seen people who have previously been infected also getting infected again, which we call reinfections, we know that reinfections are also not that common. But we also understand that natural immunity does wane over time. So there's a lot of data being collected to understand obviously how long and how protective natural immunity is in the long term. But there are also studies that have shown that people who have had previous infection and they got vaccinated, they actually had better immune responses than people who just got vaccinated only. So I think while we understand obviously that natural immunity does offer protection, while we may not know the duration of that protection, we've seen that it does wane over time. But in terms of, also protection against newer variants, the unpredictability of that immunity, I think there's more that we still need to understand in that space. But we do know, though, that if you get vaccinated when you've had prior infection, your immune response is even better. It's hybrid immunity. It's our CEO calls it super immunity. So we've seen that there's additional protection through vaccination. So I think it's important for people to understand that. And also there is a risk that comes with saying, okay, let everyone get infected and then we get our natural immunity and therefore we don't need vaccines. The problem is that it comes at a cost because we do not know how people will respond in terms of getting infected. We know people have died from the illness. And it's not only that you get infected and you may get long COVID symptoms, which we didn't know about previously, but we know now that COVID can result in these persisting symptoms. So vaccines still remain that safe way of getting people some level of immunity against COVID. I mean, I don't know if Prof would like to add anything to that, because I think it's a very important topic that comes through all the time.
Well, I can add, but I think you explained it remarkably well. Thank you. But the one thing I will say is, indeed, one of my sons sent me a message saying one of his friends is saying, well, he's had COVID. Why does he need a vaccine? So I had to send a WhatsApp. Well, 1, 2, 3. I literally put points about why, and it's exactly what you say. If you've got antibodies, say from the first wave, they are not very good at protecting against the Delta variant. So you can't assume that you've had it and therefore you're going to be protected against new variants. That's number one. Number two, as you say, is we don't know how long it's going to protect you. And also, some people will have a much more robust initial immune response than others. The third thing, and Nalutanda, you mentioned it, it's incredibly important. Perhaps there might be people on here who are suffering this, but we now know that long COVID is much more common than was initially realized. 10, 15%. We've now got our first long COVID clinic established in South Africa. The UK, through the National Health Service there, has set up long COVID clinics, and it varies from fatigue and minor disability to really profound. People talk about life-changing disability, and the worry about it is that it can occur after mild disease and it can occur in young people. The one thing we know about vaccination, not only does it stop severe illness, but the studies have now shown that it will also reduce the occurrence of long COVID. So if you're a young person and say, I've had it, I don't need it, think again, because you do not want long COVID, because it will change your life. If you get that, it will really change your life in the most miserable way at its worst. So if nothing else, think about your quality of life now. You've got antibodies, boost them well, and you're going to continue to be protected.
Professor Rees, I have two follow-up questions based on questions that people have asked. The one is that both of you have mentioned that you don't know for how long natural immunity lasts, that it could wane, but we also know that the immunity of vaccines wane. So what is the difference, really? They both wane. And secondly, you've mentioned long COVID. Can you get vaccinated if you have long COVID? Because the health department says if you have COVID, you must wait for 30 days before you get vaccinated. So what happens with long COVID? If the symptoms persist, is it still okay to get vaccinated then?
Well, starting with that second question, it's a good question, because what we're saying for most people is wait from the time that if you have mild symptoms from the time your symptoms started. If you have mild symptoms, wait 28 days. And we're saying if you have severe symptoms, again, give yourself a month. And the reason for that is that your immune system has gone into overdrive acutely in response to that acute infection. Now, with long COVID, what seems to be happening, and we're only beginning to really understand it, is that the immune system seems to have got recalibrated to continue to actually harm yourself. And it's a problem. So it's something to do with your immune response now continuing to act, say, against your heart, against your lungs, against just making you feel fatigued, against the nervous system, the brain. Anxiety is common. So this is something that seems to be a longer term immune response that we're still beginning to understand, but it's not the same as the acute response that you get when you've got COVID. So I would say that for that, if you've got really bad symptoms, have a discussion with your practitioner. But if your symptoms are mild and you're more than a month since your acute episode is over, then I think you should consider having a vaccine. So that's your long COVID. Now you're saying, why don't we just leave it all to natural infection? And Nalutanda also referred to that. What we're going to see in this country, because we've had 3 waves and we haven't yet managed to immunize the numbers of adults in the first instance that we want to immunize, we're going to see that we'll get community protection through a combination of people who have had natural infection and people who've been immunized. But we don't know for how long, as we've said, that natural infection will protect. And if people start to get reinfected, we get a new variant and we get another huge wave because their antibodies are not protecting, then we're going to go on doing this. And the same with vaccines. We don't know how long they're going to protect. So with vaccines, we're saying, let's give ourselves as individuals the best chance to be individually protected. And in so doing, we get community protection because we build up the number of people in the community who are protected against infection. And if we get enough people in the community protected against infection, then for those individuals, say the immunocompromised we just heard about, who can't have a vaccine or the vaccine isn't going to work so well, by protecting ourselves in large numbers, we're going to protect those people because we're not going to have as much virus going around between ourselves who are healthy. We're going to protect those people who can't get vaccines. So for the moment, and if we want to go back to something near normal with, soccer matches and rugby matches, clearly I've got sports on the brain, restaurants and clubs and, churches and religious worshipping, then if we want to go back to as near normal, the more of us who have antibodies, either from natural infection or from vaccines, the better. And the more we boost you, even if you've had natural infection with a vaccine, the less likely you are to get an infection and then continue to transmit.
Just to stay with you, because I know SAPRA looks at this, has anyone died of a vaccine in South Africa? And also, are there death figures from other countries? Has anyone died of COVID vaccine, globally and locally?
So in South Africa, we've got an app that you can, as a member of the public, you can download and you can put data onto. But we're training healthcare workers in particular, if they see any sort of adverse event, to put onto the app. And so an adverse event can be anything at all. So it can be a skin rash. Can be an upset stomach. It can be anything that happens within a period after vaccination. And those are reported. And then what happens is that they are analyzed. We have a special ministerial committee that analyzes it together with SAPRA and the Department of Health. And we have experts who train to look at what we call causality. Is there a possibility that what we saw in this person as a reaction to a vaccine is actually caused by the vaccine? Or was it just bad luck that they went out and ate some bad food the night before and got bad vomiting and diarrhea, for example? And then we look at causality. And we do the same with every death. Just remember that when you're immunizing, as we're trying to do, millions of people, including the elderly, including people who are vulnerable because of comorbidities, even without a vaccine, if we followed people up over a period of time, some people sadly would die because of their disease, because of their age, just because of life. And so we have to be able to differentiate between people who are dying because of life and death and what happens, and other comorbidities and age, versus is that death that we're seeing actually possibly causally associated with the vaccine? So far in South Africa, we have not seen, we continue to do these analyses all the time. We haven't seen a death that's been associated. Worldwide, the deaths that have been associated have been with some of these very, very rare side effects that we've just mentioned, the heart inflammation, the peculiar thrombotic diseases associated with the adenovirus vaccines, and very, very, very rarely would be a severe allergic reaction, because now vaccination sites are very geared up to manage that very quickly, and that can be managed.
Thank you, Professor Rees. Dr. Nemashorani, there is a question about side effects, something I've often heard people say, and it's Lisa who's asking, my period stopped for 2 months after taking the vaccine. I would like to know why this might have happened. Is this a documented side effect of a COVID vaccine, and does it commonly happen?
So this is an interesting side effect that has actually been reported. Prof would know. Some of our own South African ladies have reported to SAPRA that they have seen menstrual irregularities post-vaccination. And I think in last week or so, we've also seen globally that there is a study now to actually follow up women who have had this side effect to actually understand exactly what causes this side effect, but it is a documented side effect. Some women obviously experience this, but their periods return to normal afterwards. So it is still something that is still being investigated, but definitely reported. So it's not something that has not been identified yet. So I don't know if Prof wants to add in terms of what they're seeing from the SAPRA side.
No, I think that this is something that's being investigated, and to see whether this is something that's real, or again something that would be happening in a number of women just anyway, or whether this is actually an association. And if it is an association, we will try and understand more about it. But if it was an association, it would be something to do with the immune response.
Professor Rees, Craig Skuman wants to know if you can travel to all countries internationally with Pfizer and J&J, and we saw the launch of our digital vaccination card this morning. And I know that I've seen on social media some people say they can't get into some countries if they've only had J&J. Why is that, and how does it work?
Well, it's a really interesting, and I think it's one we're going to have to keep watching that space. And as you know, we've already had a small group of us as scientists and chairs and leaders of different committees had a meeting with the UK government recently to discuss the red flag that was attached to South Africa. And we had a very good discussion with our colleagues from the UK, who are scientists as well. And what we were able to do there, which was very encouraging, was to present the data. And this is where South Africa has been, I think, outstanding in being able to generate data about what's going on, which variants, what's going on in the region. And it was well received. And as you know, we're now off that red list. But that doesn't mean to say that there aren't still all sorts of funny things happening between countries and what their expectations are. The second thing that people are worrying about is this idea of people being selective about which vaccines they recognize. If you recall, the UK a few weeks ago said they wouldn't recognize the AstraZeneca vaccine when it was manufactured from an Indian site, same vaccine. And that, there was a whole dialogue that was reversed. So certainly one of the things that globally, and this is something the World Health Organization is looking at, is to try and get some sort of standardization. Because if countries start to cherry pick vaccines, or cherry pick where they're manufactured, or cherry pick countries and say, you can come in, you can't, little change, you can't, it's going to be chaos. Because one of the things that will get the world economy back and going, and we'll get our tourism back and going, which is very important for countries, not only like this, many countries in the world, is to actually have freer movement of people. So in terms of what you're asking, it's going to be very country specific, and it's changing very quickly. A country might say this today, but they'll say something different next week. So WHO is trying to look at this and trying to get countries to have much more standardized agreements about which vaccines we're going to recognize. One way to do that is to look at WHO status, but then there are vaccines that are recognized in their own countries, being given to millions of people. What about those? So we're going to have a standard global way of recognizing vaccines and a standard way of being able to read people's certificates. And this is why in South Africa, we've gone for an electronic certificate. And globally, the trend will be definitely to have a global electronic certification.
Thanks, Professor Rees. We've got about 2 minutes left. There is a question that I would like us to end on that you both could perhaps respond to. It relates to Israel that have vaccinated a large part of their population, but we still see people getting infected and who've been vaccinated, and we also still see deaths and hospitalizations. So quite a few questions here about what is the use of vaccination then if we still see these hospitalizations and we still see some deaths and lots of infections. Why are we pushing so hard for vaccination? Dr. Matsurani, you can start, yeah.
I can start. I think people need to also when they look at data, they must understand exactly the full context of the data. Israel, at the time when they were hit by their wave, I mean, they had vaccinated a significant number of people, specifically in the older age groups. There are various reasons why we saw what we saw. First, the Delta, which was highly transmissible, hit Israel. The younger population in Israel was still unvaccinated, so they saw some of the infections happening in younger people in Israel. But what people need to understand is that even though they started seeing an uptick in infections specifically driven by unvaccinated people within Israel, yes, there were some breakthrough infections, but they still had good protection against severe illness and death, where you still saw people that were vaccinated still having lower likelihood of getting hospitalized and lower levels of death. So you would still have to compare vaccinated against unvaccinated, even in the Israel context. So I think that's important. Prof?
Yeah.
Well, again, from the Israel point of view, or also from other countries, where we do tend to see these infections and hospitalizations, often in older people. And one of the problems as you get older, just like everything else goes wrong, like your eyes, you need to wear glasses, your immune system gets weaker. And so it doesn't respond as well to the vaccine. And that's why people are talking about boosters, particularly in the very elderly, the 80, 90-year-olds. But even if you boost, the immune system is just not as robust and mounted. So that group is always going to be at risk. But I'll perhaps give another example, which is Portugal. Portugal has now immunized, in Europe, is the most advanced in terms of immunization coverage. It's got extraordinarily high immunization coverage. If you look at their cases, their hospitalization, and going back to normal, I can tell you, I would go live in Portugal rather than in a country with no vaccine, because that is how we are going to get back to normal. It is vaccination coverage at scale, and people really must embrace that. We want to get back to normal. We want the economy to work, and we want people to be able to have fun again. So please get vaccinated.
This brings us to the end of today's webinar. Then I'd like to thank Professor Rees and Dr. Namashwarani very much for their time and sharing their expertise. As a journalist, I'm always very relieved when I hear medical professionals speak in ordinary language, and that's exactly what you did today, making everything understandable for us. So thanks so much for your time and also for your effort to make this easy for us to understand. Next Friday at 12:30, we will talk further about vaccines, and our guests will be Professor Glenda Gray, who is the president of the South African Medical Research Council, and she's also one of the lead investigators in the Sisonke trial that we spoke about a little bit today. That is a trial for COVID vaccines among healthcare workers. And we'll also be joined again by Dr. Noluthando Namashwarani, who was with us today, and also Dr. Ron Whelan, who is the head of Discovery's COVID-19 task team. If you'd like to listen to a recording of this webinar, please do keep an eye on Discovery's social media platforms. So have a good Friday afternoon. And if you have more questions about vaccines, please do come and join us next Friday. Goodbye.